Hi, everyone. Good evening. Thank you for joining the NATF Online Support Network. We're so glad that you could join us this evening. We are joined by Dr. Margaret Fang from the University of California, San Francisco, and she is an associate professor there, and she is also the medical director of their anticoagulation clinic. So she is somebody who is very well qualified to speak with you this evening about anticoagulation and the reversal. Before I hand it over to her, I just wanted to remind everyone, if you have a question, the best way to ask it is to use the chat function. And that way you can enter it in right in there. And then once we move over to the Q&A portion of the program this evening, I'll make sure to ask all of those questions. So without further ado, I will go ahead and hand it over to Dr. Fang.
Thank you so much, and I want to welcome all of the attendees for spending this evening on this webinar, talking about a very important topic, which is how to reverse anticoagulant effect. All right, I am moving ahead in my slides. I have no financial conflicts of interest, and I deal with this question quite a lot as the medical director of our anticoag clinic, where we manage people on Warfarin or Coumadin, as well as a number of the direct oral anticoagulants, and also deal with this as a hospital-based physician, where people come in with complications of anticoagulants. So I want you to think to yourself about whether you're taking an anticoagulant or someone you know is taking an anticoagulant, and what do you do if you're taking Coumadin and on your routine monthly blood test, your INR is 8. Or you're taking dabigatran, Pradaxa, and you just have this nosebleed that doesn't stop, it just keeps bleeding and bleeding. Or you're taking apixaban, Eliquis, and suddenly, after using the bathroom, you notice there's bright red blood in the toilet bowl. The goals for the next 30 minutes or so will be to cover some of these topics. First is to be able to name the different types of anticoagulants that are available, to know what to do if you develop serious bleeding while you're taking anticoagulants, and know what's currently available and recommended to reverse the effect of oral anticoagulants if need be. First, let's go over the different types of anticoagulants that people can take by pill. The first one are vitamin K antagonists. This is the one that we've had the longest. The most common one in the United States is Warfarin or Coumadin. And for those of you who've been on Warfarin or take Warfarin, you know that you come into a clinic every 1 or 2 months, you get an INR checked, and then the dose could be adjusted to keep your INR in certain range. There are also now newer oral anticoagulants, which are now called the direct oral anticoagulants, or DOACs. The first one was a direct thrombin inhibitor called dabigatran, or Pradaxa, and the other direct oral anticoagulants have advantages over warfarin in that they don't need their doses adjusted on a monthly basis. They're just fixed dosing either once or twice a day. After dabigatran was developed, there are a number of other direct anticoagulants called factor Xa inhibitors, and the currently available ones are rivaroxaban, which is Xarelto, apixaban, which is Eliquis, edoxaban, Savesa, and vitrixaban, Pradaxa. And all of these, and dabigatran, are fixed dosing. So these are the oral anticoagulants that we as physicians and you as patients might encounter. How do anticoagulants work? Well, typically, if you cut yourself and you're bleeding, your body wants to stop that bleeding. And so it generates a clot. And that can be really good if you don't want to be bleeding. But it can be really bad if you have some conditions such as atrial fibrillation, where a clot can then develop into a stroke, or a clot forms in a place that you don't want it, like in your legs, causing a deep venous thrombosis, or in your lungs, causing a pulmonary embolism. And in those situations where you don't want a clot to form, you can take one of these anticoagulants. And the anticoagulants act on the body's ability to clot and prevent it from clotting as much as it wants to, and you don't have a clot, or you might bleed it. So that's how anticoagulants work. Now, in situations like atrial fibrillation or pulmonary embolism or DVTs, you don't want your body to clot. But let's say you have an injury, or there's a situation where your body is bleeding and you actually do want to clot. Those are the primary risks of having anticoagulants. Anticoagulants can lead to bleeding. And in fact, anticoagulants are one of the most common causes of medication-related events that lead to emergency department visits or hospitalizations. If you're taking an anticoagulant, the rough estimate is about 3 people in 100 in a given year will have a significant enough bleeding event that they need to seek medical attention to your emergency department or a hospital. That means that 97 people will not have a significant bleeding event, but it is something to be aware of while you're taking anticoagulants. Anticoagulants don't actually cause the bleeding. What they do is if there is bleeding, say if you have an injury or there's an ulcer in your stomach, the anticoagulant prevents your body from forming a clot in that area, and it can make that existing injury or bleeding worse. That might be okay if it was just a paper cut, but there are serious or even potentially life-threatening bleeds. And the ones that we as clinicians are worried about are the bleeding that occurs inside of the head, which we call intracranial hemorrhage, or inside of the stomach or in the intestines, which we call gastrointestinal hemorrhage. So these are the types of bleeds that can cause permanent damage or require some sort of medical intervention. So, what should you do if you notice bleeding while taking anticoagulant? The first thing to do is to stop the anticoagulant. Depending on which one of these oral anticoagulants you're taking, the time that the anticoagulant effect will wear off varies. For those of you who are taking warfarin, you know that it can take several days, even up to 5 or 7 days, for the effects of warfarin to completely go away. The other anticoagulants, like the bigatrin and the 10A inhibitors, they usually wear off within 1 or 2 years, so they're short. Depending on the severity of the bleeding, we usually recommend that people seek medical attention, particularly if you're worried about head trauma, bleeding in the head, or bleeding inside of your stomach or intestine. And your clinician can help you guide whether to come in for evaluation, monitoring, or treatment. All people who have bleeding on anticoagulants should get what we call supportive care, meaning that we as clinicians will support your body until the anticoagulant wears off and to prevent you from losing too much blood. And that can include giving you intravenous fluids to keep your blood pressure up, blood transfusions if you need it, even doing some procedures to stop the bleeding, for example, inside of the nose or inside of the stomach. We have procedures that can do that. And in some cases, you may require a specific reversal agent for your anticoagulant. You can be reassured that all of the oral anticoagulants that I'm talking about here in this category now have at least something that we feel can help reverse the effect. For warfarin, we're going to talk about vitamin K, prothrombin complex concentrates, and fresh-closing plasma. For dabigatran, there's a reversal agent called idarosizumab. And then for apixaban and rivaroxaban, and potentially the other 10A inhibitors, we have a specific reversal agent called andexanet, and also prothrombin complex concentrates. So we'll go over all of these. First, we're going to cover how to reverse warfarin. Now, many of you who take warfarin probably have talked to your clinicians about the importance of maintaining a consistent level of vitamin K in your diet. The reason is vitamin K, which is found in green leafy vegetables like kale or spinach or collard greens, is used by the body to make clotting proteins. And the way warfarin works is it blocks the body's ability to use vitamin K to make these clotting proteins. And so if you're taking warfarin, then you don't make as many of these clotting proteins, and so you don't clot your blood as much. To overcome the effect of warfarin, you just take more vitamin K. So if you eat more greens, then you reverse warfarin's anticoagulant. How much greens actually will make a difference? So 1 cup of cooked greens, of spinach or kale, is equivalent to 1 milligram of vitamin K. And that usually is enough to get higher INR back down to a therapeutic one or a desirable one, or even a lower INR. If you need more than 1 milligram of vitamin K, then you can have prescription vitamin K pills, and those are prescribed anywhere from 2.5 to 10 milligrams. And this is within about a day, you will see some effect in your INR. If you need a reversal of the warfarin faster, then we do have vitamin K in an intravenous form. That means you would go to the hospital, have an IV placed, and they can give you vitamin K through the vein. And this does work faster than trying to eat greens or take a pill. It usually works within 6 hours or so. If you need warfarin to be reversed even faster than 6 hours, then we have prothrombin complex concentrates, or PCCs. And the way that PCCs work is they take human plasma, and then they, and plasma is where all the clotting proteins are floating around. And they have ways of concentrating it into doses that can be administered through your vein intravenously. And it can reverse the effect of warfarin within minutes or an hour. So right now, for life-threatening bleeding on warfarin, if you're having unstoppable or life-threatening bleeding, we, as clinicians, recommend that you get a prothrombin complex concentrate if appropriate. Now, the risk is that since you're getting a lot of clotting factors, you might worsen any clotting that's already in your body. And so that is an acknowledged risk. For places that don't have the PCCs, you can also get some clotting factors with a transfusion of fresh frozen plasma. And these are plasma that was donated by other people, and they have clotting factors in it, but just has to be given in a larger quantity in order for it to reverse warfarin's effect. So the summary for reversing warfarin is, if you just have an elevated INR, if you don't have significant bleeding, just stopping the warfarin will cause your INR to normalize or lower in a few days. Or if you just eat more greens, but it would take about a cup of cooked greens for a significant level of vitamin K. If you have a minor bleed or a dangerously high INR and you need faster reversal of your warfarin, then you can take prescription level vitamin K or even intravenous vitamin K. And for life-threatening bleeds that require hospital monitoring and management, we will give you both intravenous vitamin K and consider giving you a prothrombin complex concentrate or plasma transfusion. We're now going to move on to the direct thrombin inhibitor called dabigatran. So dabigatran, or Pradaxa, is the only oral direct thrombin inhibitor that we have, and it's used for people with atrial fibrillation or venous thromboembolism. If you take a pill of dabigatran, it works within a couple hours, so you'll have full anti-clotting, anticoagulant effect. And if you stop taking it, the anticoagulant effect usually goes away within about 2 days. If you need to get rid of the dabigatran in your body, for example, if you have a life-threatening bleed, we now have a specific antidote to dabigatran called idarucizumab, also called Paxbind. And this is a monoclonal antibody fragment that binds to dabigatran and allows the body to remove it in the urine. To illustrate what that looks like, this is a molecule of thrombin. This is something that the body uses to make clot. Dabigatran, an anti-clotting medication, binds to this thrombin and prevents the body from clotting. If you want to get rid of the dabigatran and allow the body to clot again, then here we have idarucizumab. And it's much more attractive to dabigatran, and dabigatran will preferentially bind and stick to it, and the body can just get rid of it, allowing the thrombin to do its clotting work. Idarucizumab has to be given in a hospital or emergency department. It should not be given to people who have a condition called hereditary fructose intolerance, which is a fairly uncommon condition, but if you know you have it, then you shouldn't get idarucizumab. And it costs about $3,500 per dose. So the summary on dabigatran is, for minor bleeds, or if you have to go through a procedure and shouldn't be on anticoagulant, just stopping the dabigatran for a couple of days is usually enough to allow your body to resume its clotting. For more serious bleeds, you should go to a hospital or emergency room for medical attention and monitoring. And in life-threatening situations where the bleeding is unstoppable and quite significant, we do have the ability to give you idarucizumab for cold reversal. Now we'll talk about how to reverse the factor Xa inhibitors. So factor Xa inhibitors, like apixaban, rivaroxaban, and endoxifen, these are also used for atrial fibrillation or induced thromboembolism. Like dabigatran, it works within a couple hours of taking the pill. And after stopping it, the anticoagulant effect usually goes away within 2 days. Fairly recently, the FDA approved a specific reversal agent for apixaban and rivaroxaban, and this agent is called andexanet alpha. And the way that andexanet alpha works is it binds to apixaban or rivaroxaban after being given as this intravenous dose, followed by a continuous infusion. And while you are getting it, the apixaban or rivaroxaban anticoagulants don't work. Once you stop that infusion, however, then the apixaban and rivaroxaban can start working again. So the effect is relatively limited to the time that you are getting the andexanet. And the reversal effect wears off quickly once your infusion is done. To show this, factor Xa, so like thrombin, factor Xa is something that your body needs to form a clot. And if it's around your body, will clot. A Xa inhibitor, like apixaban or rivaroxaban, binds to this factor Xa and prevents the body from clotting. If you want to allow the body to clot again, then here we have andexanet, which to the body looks a lot, or to the factor Xa inhibitor looks a lot like your own body's factor Xa. And here the factor Xa inhibitor will bind to andexanet and take it out of the way, allowing the body to form a clot again. Some things to know about andexanet is that in the studies of people who received andexanet, there was a higher than expected risk of clotting. The cost was extremely high. So per treatment dose, it was about $30,000 for a reversal. And because it's difficult to make andexanet, it's not yet available in all hospitals. So what do you do if your hospital doesn't have andexanet and you need to reverse the effect of apixaban or rivaroxaban? In that case, we recommend administering the prothrombin complex concentrate. So as you remember, this is what we can also use for warfarin reversal. It's a non-specific reversal agent, meaning it's just concentrated clotting proteins that were obtained from human-donated plasma. It's given intravenously, and the cost is expensive, but not as expensive as andexanet at $4,000. Some things to be aware of with the prothrombin complex concentrate is that you can have allergic reactions. It cannot be given in people who are allergic to heparin. And as I've mentioned before, when you're giving super high doses of clotting proteins, you increase the risk that you are going to get a clot if you get this with this PCC. And so if you had a recent stroke or a heart attack or clotting, getting a PCC can make that worse. And so we have to carefully balance how urgently it is to stop the bleeding versus the risk of having a clot, like a heart attack or a stroke. So, in summary, for apixaban and rivaroxaban, factor Xa inhibitors, minor bleeds or before procedures, just stopping the medication for 1 or 2 days is usually enough to allow your body to clot the way that it needs to. More serious bleeds, again, I advise you to seek medical attention where they may give you blood transfusions or intravenous fluids or procedures to stop the bleeding. And in life-threatening situations, I've talked about Anticoagulant as a specific reversal agent or prothrombin complex concentrate clotting protein as a non-specific agent, which are available but expensive and potentially increase the risk of clotting. So, take-home points from today's session. Bleeding is an acknowledged risk of taking anticoagulants, and it's something that we all think about very carefully when we are prescribing an anticoagulant for atrial fibrillation or for venous thromboembolism. Seek medical attention for bleeding that doesn't stop or bleeding in high-risk parts of the body, such as if you have concern there's bleeding inside of the head or the brain or inside of the gastrointestinal system or the intestines. All management of bleeding includes stopping the anticoagulant and universal supportive care. And as we've talked about today, we have reversal agents that are available for warfarin, dabigatran, and some of the factor Xa inhibitors. Because of the potential risks of these reversal agents, we generally reserve them for life-threatening bleeding situations, and they need to be administered in a hospital or emergency department setting. And know that these agents can be expensive and can increase the risk of clotting. Thank you all so much for your attention on today's webinar, and I'm happy to answer questions.
That was great, Dr. Fang. Thank you so much. What a really thorough review, and it is nice, even though they are expensive, to know that these drugs are out there should anybody ever need them. So which leads me to one of my first questions is, how widely available are these reversal agents?
I think it depends on the individual hospitals. To my knowledge, most hospitals will have the prothrombin complex concentrates for the non-specific reversal agents, and all hospitals should have vitamin K and fresh frozen plasma for warfarin. For idarosizumab, it is more available, and so I think I haven't heard of difficulty in getting idarosizumab as long as the hospital has decided to approve it. Anticoagulant is the one that seems to be the most limited, and that is partially because of it's very difficult to make Anticoagulant, and so the medication was initially prioritized for trauma centers in places that deal with high volumes of patients taking anticoagulants. And because it is so costly, not all hospitals have decided to have Anticoagulant, and some have elected to use prothrombin complex concentrates instead. So I guess in general, all hospitals should have the ability to reverse warfarin. Most hospitals probably have the ability to reverse dabigatran. And for the Xa inhibitors, Anticoagulant, I think it's an evolving availability.
Mm-hmm. Okay, and the second part to this patient's question was that they travel a lot for work, and they didn't say which anticoagulant they're on, but they were wondering if they should pack a reversal agent to bring with them, which my understanding is that's not possible, just for storage purposes and whatnot.
So you are right. It depends on which anticoagulant you're taking. For warfarin, so if you're taking Coumadin or warfarin, then the reversal agent, which it will take up to a day to work, is vitamin K. And you can have prescription level vitamin K, or you can just simply eat a lot of greens. For dabigatran and the apixaban and 10A inhibitors, those reversal agents have to be given in a hospital or emergency department setting because they're only available intravenously. And so yes, I guess the short answer is if sometimes what we recommend is if you know you're going to be in a situation where there's a high risk of bleeding, for example, going through surgery, or even some people who are planning on going skiing or in a situation where they may have some injury, then talk to your clinicians about whether you should temporarily decrease the amount of anticoagulant you're taking so that a bleeding complication is not as serious if it happens.
Okay, great, thank you. So this person wants to know they're on warfarin and they're about to get a colonoscopy, and they want to know what is your general view on what a patient needs to do prior to the procedure and the risk of bleeding during the procedure.
So that's a great question, and probably enough for an entire separate webinar. So I think it depends on what the warfarin is being used for. So let's just take, if you're taking warfarin for atrial fibrillation to prevent strokes, in general, it's reasonably low risk to just stop the warfarin for several days before the colonoscopy. And once you have the colonoscopy, and as long as they didn't do a significantly large biopsy, then to simply resume it afterwards. So previously, there was much greater use of something called bridging, where we would have people inject themselves with a shorter acting anticoagulant prior to procedures. It's not always necessary for people with atrial fibrillation, and unnecessary in fact, many people who've had a history of pulmonary embolism with DVT as well. So this is an area that I would be sure to talk to your anticoagulation clinic or your doctors. If you are taking warfarin and need to stay on warfarin, depending on the colonoscopy, sometimes it's actually pretty low risk to have a colonoscopy while still taking your warfarin. But it would require that the colonoscopy, they don't do any biopsies of polyps, and because you're getting a colonoscopy to see if you need a biopsy or a polyp. In most cases that I've experienced, most gastroenterologists would want you to stop your warfarin beforehand and then resume it after the procedure.
And does the same advice apply to the DOACs?
Yes. So DOACs, it's a little easier because they wear off faster. But in general, we do recommend for procedures like a colonoscopy that you're pretty sure may have a biopsy involved. It's usually stopping your anticoagulant for up to 48 hours before the procedure, and then after the procedure, assuming that you didn't have a large biopsy or that you're cleared by your gastroenterologist, you can just restart taking it.
Great. So the next question is, how does dose affect how much agent is needed or used to reduce or stop bleeding? For example, Xarelto 40 milligrams versus 20 versus 10.
So the question on how much andexanet to give or how much a prothrombin complex concentrate should you give for rivaroxaban or apixaban is still one that is going through some study. Let's just start with some background. If you are taking rivaroxaban at sort of higher doses versus lower doses, and depending on if it's rivaroxaban versus apixaban, you will be recommended a different dose of andexanet, either a higher dose or a lower dose. So, for example, at our hospital at UCSF, we've developed standardized guidelines and order sets that recommend how much andexanet you should get. For places, if you're getting a prothrombin complex concentrate for apixaban or rivaroxaban or warfarin, this is one where people are still studying, and the exact dose needed to reverse the effect is not exactly clear. Some people have looked for somewhat lower doses, and some have looked for higher doses of the PCCs, but I don't think that we have solid evidence. And so this is one where you may find that practice differs depending on which hospital you go
to. Okay, excellent. So they want to, well, this patient wants to know a little bit more. You had mentioned, a nosebleed at the beginning, or, blood in the toilet. When should you seek emergency medical treatment for those things?
Good question. So usually the kinds of bleeding that I'm concerned about are bleeding that occurs in the head.
Dr. Fang, you cut out a little bit.
Sip of water. So, for example, if there was head trauma or an accident, then we would usually recommend that you come in and get evaluated. Gastrointestinal bleeding is another category of bleeding that we worry about. If you notice black tarry stools or bright red blood in the stools that fill up the toilet bowl, those are usually when I recommend that you call your doctor and ask for some advice. For nosebleeds, many nosebleeds just with pressure, all of us have had nosebleeds, and if you hold it for enough time, it will stop bleeding. But it's the nosebleeds that you cannot stop, that last for example, an hour without stopping, or are gushing so much that is outside of the normal. In those situations, I do have people come to the emergency room so that they can have a specialist look inside of the nose and perhaps administer some local medication to constrict the blood.
Okay. Okay. And we have one more question, and it's kind of a general question. They specify andexanet for reversal of Xarelto, but they kind of want to know how well do these reversal agents really work, and are there any precautions or anything that they need to know if they're ever confronted with, if they ever have a bleed?
Good question. The evidence we have, or the experience we have with andexanet is still relatively limited. The biggest study was about in 200 to 300 people who were having life-threatening bleeding, and while taking rivaroxaban or apixaban. And they found that after getting andexanet, the majority of people, I think more than 80%, had control of their bleeding within a day. Now, 10% of those people, so 1 in 10, had a clotting event that occurred within 30 days after receiving the andexanet and stopping their anticoagulant. So based on this somewhat limited and very selected evidence, what I warn people about is that usually just stopping the Xarelto or Eliquis is enough if you can just wait it through with transfusions and with monitoring your blood pressure and any procedures needed. That's usually enough. Your body will get rid of the anticoagulant medications within about a day or two. If the bleeding is life-threatening, so for example, I've mentioned intracranial hemorrhage, where the bleeding occurs inside of the brain and mimics a stroke, and you really, it's very important to stop the bleeding completely. Then those are, I usually recommend saving andexanet for those life-threatening situations, acknowledging that they're, even though they seem to work, in our preliminary experience, that the risk of clotting is certainly there. And so beyond that, there may be other adverse effects and side effects that we are not aware of. And so I think it's very important for all of us in the medical community to keep track of how often we use andexanet and the outcomes afterwards.
Okay, so we did, if you have a moment, we got one last question come in. And this is a patient says, in Canada, some hospitals give out informational pamphlets advising patients on warfarin to skip one dose if they are not eating due to illness or vomiting, and then to resume and recheck INR in about 3 days. And they want to know if any facilities do this in the United States.
I can't speak for all facilities, but at least for our local facility at UCSF, it's I think a case-by-case basis. We don't have a general policy where we always say so, but I do think the sort of the spirit of that advice is a good one, meaning that if there are significant changes in your health, so for example, you're getting antibiotics for pneumonia, or you are recovering from a stomach flu and haven't been able to eat effectively for a couple of days, those are the situations where we know people taking warfarin can have higher INRs afterwards. So, but it's very hard to predict how much your INR will change. And so let's just say you skip a meal for 1 day. It may not be enough to really significantly change your INR unless you're used to eating a huge amount of vegetables and vitamin K every day. So on average, it's probably okay. But if there's a significant change where you're vomiting for several days, or you're taking a new medication in particular, then it is reasonable to come in and get your INR checked within several days.
Okay. So best advice is just, if something changes, talk to your doctor or your anticoagulation clinic.
That's right, exactly. And not in not every situation, we won't recommend that you have to get evaluated in person, because we know that being on anticoagulants will just, it's not that you will not clot, it's just that it'll take your body a longer period to clot. And so kind of think to your day-to-day life, you're going to notice bruises and more easy bruises, or if, for example, you're flossing your teeth, you may notice that you bleed more easily, or your nose bleeds more easily. So that's still within the realm of normal, just takes a little longer for your body to form a clot. It is the situations when the blood loss is so severe that you are noticing some consequence from it. For example, you're getting lightheaded or dizzy, or the bleeding just doesn't stop, then it is reasonable to come and either talk over the phone with your provider, or come in for more urgent evaluation.
All right. Well, thank you so much, Dr. Fang. This was a really helpful kind of overview of a really important topic that I know both patients and healthcare providers have a lot of anxiety around. So we really appreciate you taking the time to speak with us about this.
You're very welcome, and best wishes to all of you.
Thank you, and thanks everyone for joining us tonight. We hope to see you on July 9th at 7 p.m. Eastern Time, where Dr. Steve Deitelsweig will discuss the good, the bad, and the ugly of atrial fibrillation. So everyone have a wonderful 4th, and we will speak with you then. Good night.